All right. Thank you for that, Dr. Chabra. I think you can hear me in the back. Everybody's good? Okay, so two things. First, I've been suffering with the same cough that everybody's had in the South Bay for the last 6 months, essentially. So if my voice starts to fade, just please forgive me. The other thing is thank you so much for taking time to come out and be with us tonight. You know, all of us on the panel have a tremendous amount of passion for what we do, and to see that reflected in the community and to know that you guys have dedicated your time to come and do this really means a lot to us, and it gives us a lot of feedback and kind of keeps us going. So I definitely appreciate that and wanted to voice that early on. So my topic tonight is going to be, a couple of different things. I'm going to talk about aortic valve stenosis. If you don't know what the aortic valve is and you don't know what stenosis is, that's fine. We're going to cover that early on. I want to make sure that everybody kind of comes along on this journey as I begin this talk. So I'm going to start with some basic concepts and then build upon that and talk about things in a little bit more detail as we move through the presentation. And then in particular, I'm going to talk about a more minimally invasive way of approaching aortic valve stenosis. This is a disease of an aging population that has a lot of other comorbidities and might make surgery, less desirable in certain circumstances. So we've been able to come up with other approaches to help alleviate the disease process. So that's going to be what I'm going to be discussing in detail. So to begin with, like I said, very, very kind of basic to start with. What is the heart? What is the aortic valve? Heart's broken up into 4 chambers, 2 on the right side of the heart, 2 on the left side of the heart. There's one-way valves that separate each one of the chambers. So the way that this works is you have deoxygenated venous blood or blue blood that comes in here on this side, the vena cava, superior and inferior vena cava, and then comes into the right atrium, kind of a holding chamber for this blood. From the right atrium, it comes down into the right ventricle through the tricuspid valve. This is the first of the one-way valves that blood encounters through the heart, and then gets ejected out from the right ventricle through the pulmonic valve, through the pulmonary artery, and that gets distributed to the lungs. Gas exchange happens, oxygen is picked up, carbon dioxide is given off as kind of a toxic metabolite of aerobic respiration. And then oxygenated blood returns to the left side of the heart, goes from the left atrium down to the left ventricle. The left ventricle is the primary pumping chamber of the heart. And this squeezes and generates all of the force to send blood throughout the systemic circulation. And it passes through the aortic valve. So that's what we're going to be talking about. That's the aortic valve. So left ventricle, aortic valve. And then this is just a very nice kind of graphic representation of what I'm talking about. I did borrow this from Children's Hospital of Philadelphia, so I give them full credit for it. This is something I could not have generated on my own. But it's just demonstrating the various chambers of the heart, and then it breaks it down into a little bit more detail as blood gets returned, vena cava, superior, inferior, into the right atrium, through the tricuspid valve, here, down into the right ventricle, the pumping chamber for the right side of the heart, and then gets ejected here through the pulmonic valve. And so this is happening 100,000 times a day, 40 million times a year. It's actually quite remarkable that it does it as often, as frequently, and as long as it does. Then the blood returns, left side of the heart, left atrium, left ventricle, and then out through this right here, which is the valve of topic tonight, the aortic valve, so the trileaflet valve. So when it's functioning appropriately, these leaflets are exquisitely elegant. They're thin, they're pliable, they open and close, they're literally paper thin. But again, they're doing this 100,000 times a day, so there's a lot of wear and tear, and aortic stenosis is essentially a repetitive use injury. I mean, we talk about knees and hips being subjected to this. The heart's the exact same way. So over time, these leaflets become thickened, calcified, fibrotic, so they just don't open the way that they used to. So in a normal, healthy heart, this is what we're talking about. 3 leaflets, very thin, a large opening orifice. This is about the cross-sectional area or the surface area of a quarter, somewhere between 4 and 6 centimeters squared. Over time, this is what happens. It becomes thickened, sclerotic, and the leaflets are no longer free to open the way that they used to. The causes of aortic stenosis in adults, multiple causes. The lion's share of what we're going to be talking about tonight is this one here. So age-related calcific aortic stenosis used to be called senile calcific. That was not appropriate, so they moved to age-related instead. Very common in the patient population, age greater than 65, and it's really just that, valves opening and closing so many times over the course of a lifetime. Other possible causes, infection can do it, bacterial endocarditis essentially. So you have this kind of collection or abscess that forms on the valve. Usually this is a combination of both aortic stenosis and aortic regurgitation or insufficiency. There's just an incompetence of the valve and it leaks profusely. Rheumatic fever, also triggered by an infection, but it's actually your body's response to that infection. It's the formation of antibodies to drive out the infection, the strep infection, but you have antibodies that cross-react. So they attack the bacteria, but they also attack some of the tissue of the aortic valve and can lead to a sclerosis over time. And then finally, there's a congenital abnormality or an anomaly, bicuspid aortic valve, 2 leaflets instead of the 3 that we've seen, or even unicusp, 1 valve leaflet instead. Unicusp is usually presented very early on in life. Bicuspid valves, patients know about murmurs from the time they're in childhood, maybe picked up in kind of sports screening or something like that. They develop aortic stenosis earlier on in life than this patient population. So usually they're looking at aortic valve surgery in their 50s or early 60s. So these are just kind of gross anatomical images of what I'm talking about. This is a nice depiction of what that calcium looks like. It gets deposited on the leaflet body. And you can see how as this builds up or accumulates over time, it's really going to restrict that leaflet opening. The leaflets are relatively free of calcium, so the leaflet tips actually do maintain some degree of excursion, but the body is really where the obstruction comes in. The black and white is just a CAT scan, essentially. So normal anatomy, normal tri-leaflet valve, a very mild degree of calcific thickening, and then just gradual progression over time, significant calcification, and probably some degree of functional stenosis associated with that. And this is just a quick, same thing. So you can kind of see what I'm talking about here. The leaflets move nicely at the tips, but then at the body they're very thickened and calcified and there's restricted movement. Prevalence of aortic stenosis. So why are we even talking about this? Why is this an issue? Because it's common and it's only going to become more common as our patient population, particularly that age greater than 65, that elderly population continues to grow. It's estimated anywhere between 3 and 5% of the population age 3 and 7% of the population age greater than 65 has some degree of aortic stenosis, whether that be mild, moderate, or severe. So how does that break down? So if you use the lower end of that estimate, 3.5%, 4% of that patient population, it's about 40 million in the United States right now. You're looking at somewhere between 1 and 2 million people that have some degree of aortic stenosis. Of those, about a third are going to have severe aortic stenosis. And the severe aortic stenosis is really a diagnosis that we make in the office, typically with a transthoracic echo, for example. And then about half of those patients are going to have the severe symptomatic aortic stenosis. And that symptom is really the trigger that tells us as physicians that something else needs to be done, and that really is going to be aortic valve replacement. This is the SHU. This is Ohio State. This seats about 100,000 people, so it's literally 2.5 stadiums full of people with severe symptomatic aortic stenosis in the United States right now. That's a home field advantage right there. So this is why it's really so relevant, because the population age 65 and above and age 85 and above is absolutely exploding at this point in time. You know, at the turn of the century, 1 in 30 patients was age 65 or above. Now it's 1 in 8, okay, and it's only going to continue to grow. I mean, medicine has been marvelous from this standpoint, but our longevity is just continuing to increase. So as you break it down, we're looking at about 40 million people right now, age greater than 65. By the time you get to 2040, double that, 80 million people in the United States alone. Worldwide, 2050, you're talking about 2 billion people, age greater than 65 or above. You extrapolate that, you say 7% of that patient population has severe or some degree of aortic stenosis. It becomes massive numbers very quickly. And this is kind of the crux of the situation, because as these patients get older, they're the ones that have aortic stenosis, but they're also the ones that have other comorbidities that increase their surgical risk dramatically. So depending on, you know, what case series you look at, it's estimated that anywhere from 1/3 to 1/2 of patients who, by definition, meet the criteria for aortic valve replacement, unfortunately aren't offered that option because they're deemed too high risk for surgery. So obviously something else needs to be done in order to alleviate this, because there really is no medical management for aortic stenosis once a patient becomes severe. And once a patient becomes severe and they don't have aortic valve intervention of some point, the prognosis is fairly bleak. So you're talking about a 50% chance of death, a 50% chance of mortality within 24 months of making that diagnosis. Real straightforward symptoms of aortic stenosis, the things that people will be looking for: shortness of breath. It's a manifestation of heart failure. Blood can't move in the forward direction because of this aortic valve stenosis. You can't compress a fluid, so it has to go somewhere. It backs up into the lungs get heavy and wet, and patients become short of breath. Syncope, losing consciousness, just not enough perfusion to the brain because of this fixed stenotic valve. Chest discomfort, palpitations, and unfortunately sudden cardiac death. There's a small percentage of patients whose manifestation of symptomatic aortic stenosis is sudden cardiac death. Diagnosis, like I said, there are very fixed criteria for the diagnosis of severe aortic stenosis. This is just a transthoracic echo. The numbers aren't particularly relevant. This is just to reinforce the fact that there are strict criteria to make that diagnosis. So how is it managed? For patients with less advanced disease, kind of in that mild to moderate range, it's really just follow up with your cardiologist or your general practitioner and serial echocardiograms, depending on the degree of severity. Echoes anywhere from annually to maybe once every 5 years if it's very mild and the patient's relatively asymptomatic. In advanced stages, meaning severe symptomatic aortic stenosis, surgery is the correction, or some sort of fix of this aortic valve. It's a mechanical problem that needs a mechanical solution. There's no medical treatment to reverse aortic stenosis. There's no medical management option that decreases mortality. Indications, again, for valve replacement: severe symptomatic aortic stenosis with left ventricular systolic dysfunction. The heart just doesn't squeeze the way that it should. Or if a patient is going for an open heart surgery of another type, whether it be bypass surgery or valve surgery, and they have at least moderate aortic stenosis, the valve should be intervened on at that point in time. So surgical management, again, this is the standard. This is the gold standard of therapy for aortic stenosis, and I would be the first to admit that. And I'm sure Dr. Jackson would reiterate that fact. But the issue is sometimes patients are just too high risk. Going back to that previous slide, sometimes patients are just not offered that because the risks of the surgery are either prohibitive or too high risk. So other options needed to be evaluated. And this is what has been devised. So it's a transcatheter approach, meaning small tubes through small incisions, either blood vessels in the leg, through the femoral artery, or through a small incision to go directly through the apex of the heart. And I have some images to kind of depict that. The idea here is it's a balloon-mounted valve, essentially. So it's kind of like a stent. If anybody's had percutaneous intervention and stent deployment, the technique is analogous, I would say. But the balloon with the stent mounted to it is advanced across the aortic valve. The balloon is inflated. The stent is kind of this metal meshwork, and it literally locks into place with all of the calcium that's pre-existing, and it moves the old leaflets out of the way. And the leaflets aren't cut out or removed. They remain in place. Everything is just pushed to the periphery, and the balloon is deflated, and that valve is actually just left in place. So right now, these are the three traditional, I guess I would say, if you can say traditional for a technique that's only been around for about a decade, but approaches for transcatheter aortic valve replacement, starting with the transfemoral, so going through big blood vessels here in the leg, right in the crease. If that's not an option, whether it's because patients have excessive tortuosity, maybe the blood vessels have a lot of turns and that puts an increased risk for vascular injury, or there's a lot of calcium, or the blood vessels are just too narrowed, then alternate approaches include this, which is transapical, going right through the apex of the heart, more of a direct approach, but it is a small incision in the lateral chest wall, or transaortic, kind of coming from the top down. This is what the valve looks like. This is an Edwards Sapien valve. There are really two commercially available valves on the market right now. I'm not really going to talk at all in detail. This is not an endorsement, but that's just what this valve actually is. So this is the Sapien valve, and this is what it looks like mounted to the balloon on the catheter. So this is what's passed up the blood vessel across the aortic valve. This part spans that stenotic aortic valve. The balloon is here, the balloon is inflated, and then that remains, that stays there. And then let me just run this, because this kind of goes in a little bit more detail about what I just described. So what they're showing here is the transfemoral approach, would be the catheter coming up from the leg. So there's your calcific stenotic aortic valve not opening appropriately. Those are your coronary blood vessels right there coming off of the aorta. This is how we start every procedure. It's a very thin, flexible, forgiving wire that's advanced up around the arch of the aorta, crosses the aortic valve, and is positioned in the left ventricle. And then everything else rides along this wire. It's kind of a railroad track for us. First, we put across a balloon and do a valvuloplasty. We actually pace the heart to put it in temporary cardiac standstill so as to not shift our equipment when it's across the valve. So the first part is a valvuloplasty with the balloon, and then this is the device being advanced. This is all done under fluoroscopy. It's done in our hybrid operating room in the Lundquist Tower. So the device is placed across. There's the valve. The heart is again paced at a fast rate, usually 160 or 180 beats per minute. You get cardiac standstill, so this doesn't get moved or shifted. The balloon is inflated, the valve is deployed, and then everything comes out, and the valve is obviously immediately functional at that point in time. The entire procedure takes, beginning to end, maybe 2 hours, an hour and a half to 2 hours. And as of this Tuesday, we've done 45 of these, and that's pretty remarkable. I did a presentation a year ago talking about the initiation of this program here at Torrance Memorial, and to cover that much ground in that period of time, I think really is quite remarkable. And it has everything to do with the amount of support that we have here. So again, this is what the valves look like. Edwards Sapien, first generation, second generation. There's actually a third generation. With every generation or iteration of the valve becomes smaller. The device, the tubes, the catheters become lower profile, so we have to put smaller holes in blood vessels. Every one of them is handmade. It's incredible. You start with a piece of cow pericardium, which is the sac the heart sits in. It's about the size of a basketball. It's about the surface area of a basketball. The pericardium gets processed down to 3 leaflets that are about a ½ an inch in diameter each, and those are all hand sewn to this metal meshwork. In the cath lab, the valve comes already deployed, and then we put it in this device, and it's actually kind of crimped down onto the balloon and then advanced. So it's assembled in the cath lab while we're getting access. And this is, I think this is the core focus here, and this is why it's been so successful here at Torrance Memorial. It's the idea that this procedure is not done by one person or 2 people. It's not a cardiologist or an interventional cardiologist and a surgeon. It really is a team. It's a lot of people coming together, and this has happened from day one here at this institution. Administration got on board. They felt that this was the right technology at the right time. They brought on the right people, and it's been nothing short of an absolute success. I think any one of us up here would voice that opinion. Most community hospitals in their first year are doing about 23 valves. We did 45 in our first year, and we haven't even completed that. We still have about a month to go, so we might approach 50 valves in our first year, which, you know, I mean, not to pat ourselves on the back, but that's more than UCLA did in their first year. So I think that's quite remarkable. And it's been really well received from the community standpoint as well. So I love this picture because this is literally what's happening during these procedures. This is from our dry run. So this was done in the old hospital, in the old operating room. I think it was OR 21 or something like that. It was my first time in the operating room there. But I've counted this. I think there's 17 people in this frame. There's probably twice as many in the room at the time this picture was taken. And there's still just about this many people involved in each one of these procedures. And I'd be remiss if I didn't mention two other physicians that are here. This is Dr. Salman Azam. He's been here for about a year. He works with Dr. Chabra, and he's been absolutely instrumental in getting this program off of the ground and running. He brings a wealth of experience and just knowledge and confidence. And then Dr. John Stoneburner here with his back to us. He's another cardiothoracic surgeon. Again, has really been pivotal in trying to get everybody on board in adopting this technology and making this program a profound success in its first year. That's me right there. There I am. I'm actually part of the team. So advantages and limitations of conventional aortic valve replacement, which is AVR or SAVR or SAVR, versus TAVR, TAVR, the transcatheter. From conventional surgical aortic valve replacement, and Jack will probably talk a bit about this in more detail, advantages. It's an easy operation, and that's not to belittle anything or anybody, but again, this has been done for 5-6 decades now, and the surgeons are very good at what they do from that standpoint. Decades of evidence and really excellent results. The morbidity and mortality in the right patient population has been fantastic. The limitations are the obvious ones. It's invasive, it's a sternotomy, or it's a mini sternotomy. There are more minimally invasive ways to go about it, but it is still an open heart surgery. Intubation is a requirement, and patients have to go on pump to have this done. It's done on with cardiac standstill. As opposed to the transcatheter approach, the advantage is less invasive. Again, one of the obvious is intubation is not necessarily required. We're actually planning to do our first patient under sedation, but not general anesthesia next week. So this is kind of a new step for us, but it's kind of making this as minimally invasive as possible. No pump. Patients don't have to go on bypass. The limitations, aside from the fact that this has only been around, the first in-man valve went in 2002. The first valves were improved in Europe in 2007 and here in the U.S. in 2011. So we have less than a decade's worth of evidence. I think at this point we're talking about somewhere around 70,000 valves implanted. There are about 70,000 aortic valve surgeries performed every year. So you can see the numbers are quite different. Aortic regurgitation or leakiness of the heart valve, that's still something that we're grappling with. And with every iteration of the valve, there are new ways of dealing with this, but you can imagine as this valve goes in and crunches all of this calcium, which is essentially the same density as bone, against the walls of the aortic annulus where this valve sits, you can have gutters form. If you have two chunks of calcium, there's nothing that's going to fill that gap, and you can have regurgitation there. So newer valves have skirts or linings that help kind of cushion or fill that, and it's really reduced the incidence of aortic valve regurgitation. Stroke is another big one. We get in there and there's nothing more sophisticated than crunching happening. We're just kind of blowing this aortic valve open, and if there's calcium that comes off, it can go anywhere. If it goes to the brain, it can cause a stroke, and those are numbers that we're also working with lowering, whether it's through strategies like some sort of capture device or net that obstructs blood flow or can catch that flow going to the brain, or choosing the right patient. Maybe there's some patients that are going to be higher risk for stroke. This won't be the right procedure for them. Vascular complications, again, this is with every iteration, of technology, the sheaths that we use are getting smaller in diameter, decreasing the risk of vascular complications. And then there is a need for pacemaker with this. Depending on which valve you use, it can be anywhere from 5 to 20%. So these are just kind of the honest limitations of the procedure as they stand today. So in conclusion, I think these are three relatively safe statements to make. So TAVR represents the standard of care for patients with severe symptomatic aortic stenosis who are deemed inoperable. So those non-operable patients, and the partner trial, kind of the pivotal trial that established the benefit and the efficacy of that Edwards valve, It demonstrated a 20% absolute reduction in mortality at 1 year, and that's unheard of. You really don't get that anywhere else in medicine. That was a profound benefit from a single strategy. TAVR is seen as an alternative treatment option to surgical aortic valve replacement in a subset of patients with high postoperative risk, and that's where that heart team comes into play. Every patient that's considered for TAVR in this facility, in this institution, goes through a pretty stringent vetting process. It's a meeting that happens every Wednesday. We're all there. We're there every single morning at 7 a.m. Patients are presented, all of the data, the risk factors, and the decision is made as to what's most appropriate, in our opinion, for that particular patient. And that's what's happening across the United States. You don't put in a transcatheter valve unless you have a heart team in place to help make those decisions. And then evolving, improving technologies and techniques will continue to improve safety and efficacy of this less invasive strategy. So whether it's smaller caliber catheters or devices that are retrievable, so if you don't like the position, you can go in, take out that aortic valve, and then redeploy it. These things are constantly being worked on by the engineers at various device manufacturing companies. And that's the general lay of the land. Thank you for your time. I really do appreciate it.